Welcome to this Medical Explainer. We're jumping right into the clinical data today to see exactly how mesenchymal stromal cells, or MSCs, are being investigated to treat severe diabetic wounds. If you follow regenerative medicine, you know this is a massively hyped area. But today, we're cutting through all that noise to break down the actual science.
So, can stem cells actually heal these stubbornly difficult wounds? To answer that, we've got to understand the battlefield. Why do chronic diabetic wounds, especially diabetic foot ulcers, resist standard treatments so fiercely, pushing patients towards severe, life-altering complications? Well, to grasp the solution, we have to deeply understand the problem.
Here's our treatment plan for this explainer. 1. The diabetic wound crisis. 2. Barriers to natural healing. 3. How MSC therapy works. 4. The clinical reality. And finally, 5. The future of regeneration. Let's dive right into Section 1, the diabetic wound crisis, focusing specifically on understanding diabetic foot ulcers.
Let's clear up a huge misconception right off the bat. A diabetic foot ulcer is not just a skin problem. It's actually a complete systemic failure. Persistently high blood glucose systematically damages blood vessels and nerves. So we're not just talking about a localized cut that needs a Band-Aid, we're talking about a dangerous breakdown in the body's entire circulation network. And that makes natural healing incredibly difficult.
It's a terrifying, step-by-step progression when a wound deteriorates. Look at this cascade. Because blood vessels and nerves are damaged in steps 1 and 2, the skin inevitably breaks down in step 3. Then it hits the soft tissue. Without proper circulation to fight it off, severe infection sets in, eventually reaching the bone at step 6. If it gets to that final stage, tissue death occurs, and amputation often becomes a tragic necessity.
Moving right along to Section 2, barriers to natural healing. Why exactly won't these wounds close on their own? What's going wrong on a cellular level?
For these patients, several biological barriers hit all at once. It's a perfect storm. Poor blood circulation literally starves the wound of vital oxygen. Chronic inflammation derails the normal healing timeline, locking the wound in a destructive state for months. The cells meant to repair the skin become sluggish, meaning tissue regeneration is impaired. And when you combine all of that with poor immune function, you get a massively higher risk of infection.
Of all those barriers, peripheral neuropathy is probably the most insidious. This nerve damage acts as a silent catalyst. Because sensation in the feet is decreased or totally gone, a patient might step on a tack or have a pebble in their shoe and literally not feel the injury happen. By the time they actually notice it, the wound has already bypassed the early stages and become severe. Let's transition to Section 3, how MSC therapy works. We're going to look at these cells not as simple building blocks, but as cellular directors.
We have to bust a major myth right now. You've probably heard that stem cells simply turn into new skin. It's a great sci-fi concept, but for MSCs and diabetic wounds, it's just not accurate. They don't act as mere building blocks that magically transform into fresh tissue to plug the hole.
Instead, they work through bioactive factors. Think of MSCs like project managers arriving at a totally chaotic construction site. Instead of picking up a hammer and becoming the drywall themselves, they release these signaling molecules. These bioactive factors give clear, targeted instructions to the surrounding damaged tissues and actively change the entire wound environment. So what exactly are those instructions? Well, these bioactive managers trigger 5 critical healing mechanisms. They promote angiogenesis, support tissue regeneration, regulate that chronic inflammation we talked about, support the survival of existing cells, and ultimately, they're being studied for the potential to accelerate overall wound closure. Basically, they shift the environment from chronic destruction to active repair.
What is absolutely fascinating here is the specific focus on angiogenesis. Remember how poor circulation starves the wound? Well, this mechanism is a real game changer. By releasing molecules that stimulate the formation of new blood vessels, MSCs help rebuild that microcirculation network. They effectively restore the delivery pipeline of oxygen and nutrients the wound desperately needs to survive.
How does this actually translate to the clinic, though? When researchers look at the data comparing conventional treatment alone to conventional treatment combined with cell therapies, the results are super encouraging. While study designs do vary, clinical data and meta-analyses show that adding these cell therapies can lead to higher complete healing rates and much greater reductions in ulcer size than standard care alone. But we need a reality check. Welcome to Section 4, the clinical reality. Because in medicine, there are no magic bullets. This might be the most crucial takeaway of this entire explainer. MSC therapy should not replace standard diabetic wound treatment. Let me repeat that. MSCs are currently an additional investigational approach. They are absolutely not a replacement for the vital, day-to-day work of qualified healthcare professionals managing these incredibly complex cases.
These standard management steps, they remain completely non-negotiable. Rigorous blood glucose control, physical cleaning and debridement of the wound, aggressive infection treatment, pressure offloading, literally taking the physical weight off the foot, and vascular assessments to surgically restore blood flow if needed. These are foundational. Without them, infections and reduced circulation can progress so fast that no cellular therapy could ever catch up.
And that brings us to the most terrifying prospect for any patient dealing with this: limb loss. The big question is, can MSCs reliably prevent amputation for every single patient? Is this a guaranteed safeguard? The honest, factual, clinical answer is no. It would be totally inaccurate to say MSCs guarantee limb salvage. While some studies in patients with impaired limb circulation have reported improvements, a successful outcome is never a sure thing. It heavily depends on a complex web of patient-specific factors: the depth of the infection, kidney disease, blood glucose control, and even smoking status. All of these drastically impact whether the cells can actually do their job. Which brings us to our final section, Section 5, the future of regeneration and how we might restore biology itself.
This concept really perfectly captures the true promise of regenerative medicine. The goal isn't just to find a better biological bandage to slap over an open wound. The goal is to fundamentally fix the body's broken healing machinery. It's all about restoring those deep biological processes so the body can finally execute the effective, natural healing it was designed to do in the first place.
But to get there, we still have work to do. Because MSC therapy is still investigational for diabetic wounds, the medical community urgently needs larger, standardized clinical trials. We need the hard data to finalize these crucial protocols, like determining the optimal cell source, the exact required dose, the best administration method, establishing rigorous safety parameters, and proving long-term effectiveness. All of that has to happen before this can become a widespread standard of care.
As we wrap up this explainer, I want to leave you with this to ponder. If we can successfully harness stem cells to repair the broken signaling in diabetic wounds, if we can truly restore the foundational biology of healing, what other devastating chronic diseases could regenerative medicine conquer next? Mastering cellular communication here might just be the key to unlocking healing across the entire spectrum of human disease. Thanks so much for joining me to explore this fascinating science.